Now, for the next talk, we have none other than Dr. Steve Nissen, and I think what cardiovascular is the cardiovascular safety studies with diabetes drugs actually were probably one of the reasons the FDA changed is after Dr. Steve Nissen's findings on glitazones earlier a decade ago. He's the chief scientific officer, Sindel and Arnold Miller Family Heart, Vascular and Thoracic Institute, and holds the Levi's and Patricia Dixie Chair in Cardiovascular Medicine. Special and clinical interest are general cardiology, intravascular ultrasound, diabetes and heart, drug safety, coronary intensive care. He's more than 35 years of experience as a physician. He's world renowned for his work as a cardiologist, patient advocate, and researcher. Equally as significant is his pioneering work in IVUS technology and its use in patients with atherosclerosis. He has testified both in the Senate and the House of Representatives on the topic of drug safety and as well the need to reform the FDA. Over to you, sir. RX team, over. Dr. Steve Nissen joined?
Yes.
Hello. Is there a recorded talk?
I think there's a recorded one.
Yeah, I asked them.
No, sir. Team RX. Yes, sir.
Recorded talk.
सर वो ज्वाइन नहीं हुए.
Do we have?
Has he sent a recorded one or is he joining live?
सर ज्वाइन हो रहे हैं वो. अभी ज्वाइन नहीं हुए सर. मेल कर दिया है सर उनको.
We'll wait for a couple of minutes and okay. Manoj and I will start the discussion on something of now. If it wasn't, if it doesn't for Dr. Steve Nissen, I don't think the FDA would have changed its cardiovascular. Wouldn't have asked companies to give cardiovascular safety data. All started with the rosiglitazone story. Then you had the musaglitazar story, and I got a message from Dr.
Sanjay, I think Dr. Abraham is here and he's ready.
I think we can.
So we could proceed with Dr. Abraham's talk, and then once Dr. Nissen joins in,
then we will move.
Thank you, Dr. Abraham.
Sanjay, please. Change. We didn't have Dr. Steve Nissen joining us, or no, we have his recorded talk. I think he's supposed to join.
You're mute, Sanjay.
No, I'm not. Manoj, can you hear me? Can you hear me? I think it's the.
Yeah. Please go ahead. Sorry.
Yeah. So we have Dr. Amar Ibrahim from the US. He's going to talk on, is it okay with wound dressing? Thanks for joining in earlier, sir. He's the General Director, Indian National Institute of Diabetes, President of the South and Central American region, SACA of the International Diabetes Federation. Over to you, Dr. Amar Ibrahim, for your talk on is it okay with wound dressing in diabetic foot, diabetic ulcer patients. Over to you, sir. Sir, you're muted. Dr. Amar Ibrahim, sir, you're muted.
Yeah, sorry. Good morning or good afternoon. Really, I'm so happy to share with you. It is my third time to participate in Diabetes India. I'm honored to be with you. The first time I participate with Dr. Shaukat Sadikot. I'm a surgeon and diabetic foot surgeon. And we'll talk about some wound dressing, especially for young physician and young practitioner, as we have hundreds of wound dressing for diabetic foot. So I'll try to do something about that. I'll share my screen. Wait 1 second, please. Okay. Is it clear?
You're perfectly clear, sir. Go ahead.
Okay, thanks. So we'll talk about some wound dressing. I have no conflict of interest. As I said, we have hundreds of wound dressing and young physician, young surgeon trying to choose the best one for management of diabetic foot ulcers. So we have something to explain and to orientate these young people. As a history, we remember the wound dressing began in the early 15th century, as you can see, with some linters, papers, cut and goes. And then after that, in the 20th century, we have a new modality of wound dressing. And the new century, 21st century, we have sensorial monitors, we have medicated polymers, chemical sensors, and so on. It's important to know that the treatment of diabetic foot ulcer and diabetic foot in general, it is a multidisciplinary approach. It is not only a treatment of ulcer, it is not only a treatment of wound. So we have to treat the infection, we have to revascularize, we have to offload the pressure of the bottom of the foot, and finally we should take care of the wound and use the wound dressing. For that, we have some important facts. Wound dressing are not a treatment of diabetic foot ulcers, never replace the correct and appropriate approach of diabetic foot. They, together with the adequate treatment of diabetic foot, will help healing of the wounds of these patients. And there is not enough evidence to support the use of any of these dressing, as we'll see at the end of this short conference. So as we know, in the chronic wounds, dermis is damaged or not exist because we have a lack of collagen, lack of fibroblasts, keratinocytes, and cytokines. What should be the ideal characteristic of a wound dressing? Should be sterile, easy to use, and cost-effective. Should provide a protective cover, maintain a moist wound healing environment, absorb the excess of the exudate, easy to change, non-adherent, non-toxic, and non-allergic. Also, does not contaminate the wound with foreign particles, protect the wound from microorganisms, allow gaseous exchange and control wound odor, provide thermal insulation and mechanical protection, and the most important, to be available in the area where you work. So for the dressing choice, we have a lot of factors that determine the use or the choice of specific wound dressing. Most important is the cause of diabetic foot, location and depth of this wound, amount of scar detachment, is this wound have high, low or moderate exudate, condition of a wound emergence, presence of infection and or pain, need of adhesions, and as we said, the dressing adaptability. How to select the adequate dressing? We have a most important criteria is the clinical judgment of the physician. Others, to keep wound bed continuously moist, keep surrounding skin protected and dry, control exudate, caregiver time, and cost-effective consideration. So for that, we have some primary consideration like moisture, drainage, control, minimized dead space, autolytical debridement, thermal protection, and external barrier. And for the advanced consideration of secondary consideration, we have enzymatic debridement, decrease in the bioburden, cellular stimulation, skin substitutes, and angiogenesis. Important to know before using wound dressing, 3 important questions. If we are able to answer this question, sure we will have the perfect choice for a wound dressing. Why to apply dressing is the first question. Second one, what to expect from this dressing. And the third question, how often they should be changed. So for the classification of wound dressing, we have three main classification as a function. Passive wound dressing, protect action, or have a protective action. Acute wounds, we use it in acute wounds, absorbable responsible amount of exudate and guarantee good protection. For active, modify the physiology of the wound, stimulate cellular activity and release the growth factor, used usually in chronic wounds and maintain a humid environment that stimulate the healing process. For the interactive wound dressing, create a moist wound environment, interact with the wound bed component to further enhance wound healing, will reduce the colonization count, will reduce the level of exudate, will improve wound bed moisture retention, will improve wound collagen matrix, and will provide the protection from the epithelializing bed. So we'll begin with the most important types of wound dressing that we can find. The first group, hydrogels. They produce non-surgical debridement agents. They rehydrate wound bed, provide moisture control, promote autolytic debridement, and to provide cooling for the lesion. We should use them in the dry, low to moderate exudate wounds with combined presentation with silver as antimicrobial activity. Contraindicated, the use in highly exudated wound or where anaerobic infection is suspected and may cause maceration of the wound borders. We have many studies and many publications about hydrogel dressing, and this is one of the most important. This meta-analysis of 3 studies carrying hydrogel dressing with basic wound contract dressing found significantly greater healing with hydrogel. So it's important the use of this component. Second one is a calcium alginate dressing derived from seaweed, come in a form of calcium alginate or sometimes calcium sodium alginate or other times with alginic acid. Form a gel that absorb exudate when in contact with wounds, help prevent scar formation and promote wound contraction, allows gas exchange necessary for a healthy wound bed. Also have a low adherence, reducing trauma at the time of dressing change. They conform to wound counters, low fiber shed, easy to remove. Calcium ions make the dressing take on a gel-like appearance and facilitate wound healing by providing a favorable microenvironment. So the action is the left side as to absorb the fluid, to promote analytic debridement, as we said. Here are the most important indication: moderate to high exudate wounds, special cavities, and with combination with silver will have antimicrobial activity. Precaution, don't use with dry or have very necrotic wounds. Use with caution on friable tissue and don't pack cavity wounds tightly because that will reduce blood irrigation. Also, many publications about alginate dressing. The third group is hydrofiber containing carboxymethyl cellulose, an absorbative textile fiber bed, also available as ribbon for packing of deep wounds. This material is covered with a secondary dressing always. The hydrofiber combines with wound exudate to produce a hydrophilic gel. Hydrophil with Ag contains ionic silver that have a very strong effect as topical antimicrobial agent and to protect against many resistant bacteria. absorb wound fluid and create a soft gel which maintain a moist wound environment, absorb and retain exudate and harmful component such as bacteria contained within exudate directly to its fiber. And as a result of that, we reduce or help to reduce the pain and the trauma upon dressing removal and conforms to the body or to the wound surface. Used in moderate to highly exudate chronic wounds. Also, many publication, and most important that conclusion we had standard care with appropriate offloading. The use of hydrofiber is so effective. We have some wound dressings that they use honey as topical antiseptic and antimicrobial. The history of honey use is for thousands of years. Its action rehydrate wound bed to promote autolytical debridement, antimicrobial action, and some topical nutrition. The indication is low to moderate exudate wounds, highly colonized wounds, and the precaution may cause drawing pain or as asthmatic effect and some known sensitivity. Also, many studies and many published papers about the use of honey dressing. One of these publications is this one that I'm presenting. That the conclusion of this study is that suggests that honey dressing effectively promote healing in diabetic foot ulcer. The second or next group of wound dressing is nanocrystalline silver. Have antimicrobial action. It is indicated in critically colonized wound or clinical signs of infection, low to high exudate wounds, and with combination of foams or alginate will increase the effect. Precaution, some may cause discoloration, some types of sensitivity to this substance, and to discontinue after 2 weeks of no improvement and reevaluate the use of this nanocrystalline silver. Also, we have combination of both with honey, and the studies between both to know which is better. Nanocrystalline silver alginate was potentially superior to honey and conventional dressing in healing diabetic foot ulcer in terms of ulcer size and reduction of the rate time for healing. Some groups are formed by foams, absorb the fluid, moisture control, and it is conformability for wound bed. We use it to moderate to highly exudate wounds, special cavities, low adherence version of available for patients with fragile skin. It is contraindicated, or some precaution don't use in dry necrotic wounds or those with minimal exudates. Also, we have many studies about that result indicates that highly hydrophilic polyurethane foam dressing may provide an effective treatment strategy for diabetic foot ulcers. Next group, we have hydrocolloids, absorb fluid to promote autolytical debridement. It is indicated in clean, low to moderate exudate wounds. Combined presentation with silver also have a very important antimicrobial activity. As a precaution, don't use it on dry or necrotic wound or highly exudate wounds. May encourage overgranulation. We have to pay attention for this point, as this overgranulation may produce highly moisture wounds and may cause maceration to the border of the wounds. As hydrocolloids, we have no research evidence suggests that any type of hydrocolloid wound dressing is more effective with other dressing in diabetic foot ulcer at least. We have a low adherent wound contract layer, most common commercially or publicly as silicone wound dressing, protecting new tissue growth, atraumatic to peri-wound skin, and conformable to body counters. Indication, low to high exudate wounds, use as a contact layer on superficial low oxidating wounds. As a precaution, may dry out if left to place for too many days, and we have some type of sensibility. Also, I can add that silicone in hot country may increase the temperature of the skin and may produce some thermic lesion, especially in people with diabetes. Is a diabetic foot ulcer pilot study. Does silicone gel sheeting reduce the incidence of the ulceration? As a result, does not seem to reduce the risk of re-ulceration, because many people use silicone insoles as a prevention of re-ulceration. And this study demonstrates that there is no way as a prevention. Next one is a PHMB, is antimicrobial action. It is indicated in low to high exudate wounds, critically colonized wounds or clinical signs of important infection may require secondary dressing. As a precaution, don't use in the dry or necrotic wounds, and if there is some sensitivity to these products. We have many studies about PHMBs, as you can see, the action and the function of this important wound dressing. And as a summary, is effective as antimicrobial agent. And if we use it with a broad spectrum of antimicrobial and low toxicity. So the next one, we have a platelet-rich plasma for diabetic foot ulcer. It has been used in recent years with a very, very important results. And the topical application of platelet-rich plasma for diabetic foot ulcer result in statistically superior healing rates and lower complication rates compared to any other control. Other study demonstrates the same. And we have the function of collagen with or without calcium alginate. There's a structural support of collagen with gel forming properties of alginase, maintains a moist wound environment and create ideal condition for healing. It is adherent, flexible, and conformable, sterile, and soft. Also, we have many studies supporting the use of collagen dressing in diabetic foot ulcers. We have dextranomer hydrophilic granules contain microspheres in dry form composed of the dextranomer hydrophilic polysaccharide. When the granules come into contact with the fluid, they absorb water and they swell until saturated. When placed in secreting ulcers, the granules absorb, exudate, and subsequent swelling and formating of a gel-like mass have been found to be an efficient method of reducing exudate and removing debris from cutaneous ulcer. Also, we have activated charcoal dressing, absorb exudate and bacteria from ulcer bed onto the dressing material, acts as a barrier and absorb and filters the malodorous chemical which evaporate and are released from the ulcer. Some dressing combine activated charcoal and silver at 0.15%, and so this combination will be perfect for odor control and infection control. So if we classify diabetic foot ulcer as a fluid production, low to moderate, and high, we can choose which type of wound dressing is more effective for low, for moderate, and for high production. Angiogenesis, always we talk about that. I think there is not enough time to talk it. It is negative pressure wound therapies, and negative pressure was first used for open abdomen with high intra-abdominal pressure. Later, they discovered the importance of this technique to close diabetic foot ulcer, especially if there is no arterial compromise. We have many studies supporting that. And finally, we have a lot of study that demonstrate that there is no superior effect or selectivity of wound dressing about diabetic foot ulcer healing in general. It's so important that for each type of wound, each type of ulcer, we have specific type of wound dressing that may be more effective for this type of dressing. Finally, question to ask when considering advanced or a new treatment. Are there other treatable reasons the ulcer is not healing, especially if we have infection, importance of vascular arterial supply, some patient factors, and the most important, I think, pressure relief. Would additional consultant be appropriate? Always we say yes, as diabetic foot ulcer treatment is not only one specialty, it's not one person, it is a multidisciplinary team. And the last question, is there adequate evidence-based medicine that the treatment or product is effective, particularly for the situation of this patient? So as we classify by the colonization and infection, you can see not all diabetic foot ulcer need antimicrobial indication or antibiotics, but if we have some criteria for infection, it is necessary the use of antibiotics. So we have many ways to choose the type of dressing related the quality of the wound, the quality of the patient, quality of vascular irrigation. And the last one we classify the wound in necrotic, sloughy, exudate, granulating, and epithelializing. And in each type of this type of wound, we have a lot of option of wound dressing to be chosen. So as a final message, diabetic foot ulcer treatment, it is not unique. It's not only one pattern. We have many ways. We should see the patient as a complete patient, not only as an ulcer. We should know exactly what is the cause of the ulcer, what are the components of this ulcer. So according to all these criteria, we can choose which type of dressing. Thank you very much. This is my email for any question in the future. Thank you, and thank you all for diabetes in India. And I think not in India, in all the world, we have to look to diabetes in India and to do the same, because you have a very, very important role in education for both physician and patient. Thank you very much.
Thank you, Dr. Amar Ibrahim. That was very nice of you to look at. The most important thing which I learned in today's lesson is all dressings are not for all wounds. Please classify the wound. Depending on the nature of the wound, choose the type of dressing, and choose dressings which have evidence base, which are affordable. In a country like us, I understand the dressings are available. One of the most common complications, diabetes foot, with an ulcer in the foot, and the man is not working for quite a long time till we know how difficult it is to heal them. And it was very insightful, your thoughts, and thanks for sharing all this data with us. Now, I just had a small question. Do you use honey in practice?
Honey as a honey, no. But there is a new dressing that you have honey as a component. And in my practice, they have some good result, especially in some patients. But we cannot use it in all the patients.
I just wanted to know, because I was impressed with some data which you showed about honey, which is available quite abundantly. And thank you very much. And Dr. Shaukat Sadikot, who I think is instrumental for founding this organization and be a good friend. So thank you, sir. Thank you for being with us. And thank you for agreeing to speak earlier, because the other speaker during his time. Thank you very much. It's a pleasure to listen to you. Thank you. I think good evening, everybody, once again, and we're coming to the end of today's event. We don't have Dr. Steve Nissen had to pull out, was not unable to join because he had we wasn't. He had an emergency, and so I think so. We were not able to connect. We tried to reach him, but we couldn't, and we regret that we didn't have a recorded talk of his. So I will. I see Dr. Bansi Sabu. I think I'll ask him to give the closing remarks, sir, for today, and Dr. Purvi.
So, Dr. Sanjay, we are done for the day. Thank you all for joining in this virtual program in the Shaukat Sadikot Hall. And thank you again, Dr. Sanjay Reddy, sir, as well as Professor Dr. Shashank Joshi, sir, for handling this session seamlessly. And with that, we come to the end of day one, and we welcome you all once again to join us tomorrow for the real hybrid conference that's going to be relayed live from Goa in India.
So she's.
I think we have Dr. Banshi with us. Maybe he can.
Yes, Purvi. First of all, thanks for you were really today fabulous to handle all three halls, and Sanjay, you have done great job. And today all sessions were online, and we were handling 3 sessions and 3 hall. Many of our coordinator and moderator were traveling to reach Goa, and we all were here at Goa, and we were handling all the halls. But once again, thanks to all international and national faculty for joining us live, and many of them could not join, so they have sent their video, but they were live for question answer. Thanks to all our delegates from all across the country, and some of the from Middle East and North Africa to join us live and they listen. And now we are just closing this whole A, but we will be waiting for all of you again from tomorrow, where real hybrid meeting is be there, and we all will be joining from Grand Hyatt Convention Center. So now good night. This is the time to celebrate. So those who are at Goa, please join us for faculty dinner, and other 2 hall are still going on. So Desmond Shaw's last talk is going on in other, and Charlene is talking in other hall. So I think maybe in another 15-20 minutes we will be ending for all the halls. Thank you very much once again. Good night.
Good night, sir. Thank you.